Fortunately, most of the information that we have about fatigue and inflammatory or demyelinating disorders of the nervous system is, like in some other areas, from MS studies. So I'm primarily going to review the literature and what we currently understand about fatigue and MS, and hopefully we can find applications from this information for other neuroimmunologic disorders. Just to speak about fatigue, in particular we're talking about a certain kind of fatigue. This has been alluded to a little earlier, a pathologic kind of fatigue. Now, there is an official definition for this from the MS Council for Clinical Practice Guidelines, and the way they wrote that up was as a subjective lack of physical and or mental energy that is perceived by the individual or caregiver to interfere with usual and desired activities. So a pretty broad definition. And an important thing there is subjective, because this is sort of one of those invisible symptoms of MS or neuroimmunologic disorders. This group divided up into acute, occurring over less than 6 weeks, and chronic fatigue. And when you talk about an MS, it's been well studied in terms of surveys of clinic populations. It is said to be the most common symptom in MS, ranging from 75 to 95%. And really, it's quite impressive that 50 to 60% report that fatigue is their worst problem. I mean, that's when you count all these bladder problems, incontinence, weakness, etc. And such a large group are reporting this as the most disabling problem. 70% are reporting this problem of pathologic fatigue as a daily problem. 22%, that's a fifth, report that it disrupts daily activities. And it's really under-recognized, or at least has been in the past. I think there's been more attention to it of late. Like a lot of the problems, like the pain that I spoke about, really the etiology and mechanisms are poorly understood, and there again, that's a challenge for treatment. One of the interesting things is that it's one of the major reasons for unemployment, and sometimes ahead of weakness and physical disability. Because certainly many people are working that are not ambulatory, but the fatigue is hard to fight off. And at least under Ohio law, there's a separate listing for pathologic fatigue to apply for disability that we use a lot. And obviously devastating effects of quality of life. So there have been some attempts to try to figure out, well, what features of MS correlate with this kind of pathologic fatigue. And so some of the early studies were just looking at, basic demographic characteristics. So one was age, and interestingly enough, that didn't seem to correlate very strongly. Sex, or gender, I should say. And then disease duration also was not a strong correlation. Then the next thought was, well, okay, let's look at the lesions that we can see on MRI. Maybe this will correlate with the number or volume of lesions, and the more brain that's visibly affected on MRI, the more likely a person will be to have fatigue. But that really didn't pan out, so several groups sat there and measured out the volume of lesions, visible lesions on MRI, and really there was no difference between fatigued and non-fatigued patients. And this is looking at sort of the whole brain at once and not looking at any special subsections of the brain. Okay, so a couple studies of that. What about depression? We just heard from Dr. Kaplan earlier about how pervasive depression is in the population, and everything confounds each of these features confound each other. So looking for depression, looking for fatigue, looking for pain, they're all interacting, and it makes it hard to separate out these things when you're studying them. But some attempts to do that have shown that really the level of disability is only weakly correlated with fatigue after you adjust out depression scores. The disease type, whether a person has a relapsing course or a progressive course, is again only weakly correlated, with progressive course being a little bit more correlated with fatigue, and same with depression. A lot more attention has been focused on depression since those early studies, and trying to apply different measures of depression. So there's some clinical scales that Lauren Krupp has used. And one of these thoughts here is, okay, first let's correlate, see if it correlates, and that was distinct. And then another thing was, well, if I treat the depression, does that affect the fatigue? Does that help the fatigue? Or if I treat the fatigue, does that help the depression? And those things did not get treated together. So that, again, is evidence that they're separate processes, even if they affect each other. So then there have been some hypotheses and some relatively simple studies trying to look at fatigue and motor function. And we know that one of the features of MS fatigue is that it's associated with physical activities. So just doing walking or housework or whatever can bring on this fatigue or exacerbate it. There have been some studies that show that there is a decreased firing of motor units. So each individual group of muscle fibers that are innervated by a motor neuron going out to the muscle may have a decreased rate of firing, and presumably that is of brain or spinal cord origin. All right, but nobody's sure exactly where that happens or where it's modulated. There also seems to be some impairment of muscular activation and metabolism during exercise. But these are studies that have been done primarily in fairly primitive ways. Okay. There are also studies trying to look at, well, if we have demyelination in pathways in the brain, then if I try to repetitively stimulate some of these pathways and they're demyelinated, maybe I can just overstimulate them and have electrical transmission fail. And basically, when they tried to take a magnet, and they can do this through the skull and fire off these pathways, really it didn't have much of effect on the making a certain muscle downstream that was controlled by that part of the brain fire. So that suggests that it's not due to fatigue in these sort of white matter pathways, or at least not entirely, and there may be a component of cortex involved. And also the thought is that there probably is some decreased drive or motor drive to motor neurons in the spinal cord due to descending motor pathways. Another thought is that there's probably a component of muscle fatigue due to spasticity. So in spasticity, there's an abnormal or excessive firing of muscles, and maybe you even have two muscles that wouldn't normally work against each other firing at the same time. So there's an inefficiency, and two muscles are working together. And obviously that could waste some energy. Okay. Another study suggested that fatigue occurs somewhere after a stimulus, but before activation of motor pathways. So in this situation, there was a stimulation given, and basically they saw a delay between the stimulus, the time of the stimulus, and the activation of the motor pathway. So this study did suggest some kind of disruption of an intracortical circuit. And then getting to more advanced technology, there have been PET scans that have shown a reduction of brain glucose use in patients, MS patients with and without MS. And in particular, in this study, there would be significant reductions in certain areas, in the bilateral prefrontal cortex and white matter. And so it seems like there's a known decrease in activity in certain areas of the brain. And this is a pattern that's different than we might see in depression. And it's thought by these researchers to support some kind of decreased interaction between the frontal cortex, sort of the basic planning area of the cortex, and the motor area. So that's kind of higher level investigation, but it still hasn't completely pinned down where this fatigue is occurring. But just to let you know that there is research going on trying to look at that. There's evidence that fatigue is a distinct symptom of MS, and some of those, not just secondary to weakness or inefficiency, and some of those are that it does show the heat sensitivity when a person's body temperature rises because of the ambient temperature or fever. The person will show more fatigue, more of this pathologic fatigue. It doesn't just come with other MS symptoms, okay? Sometimes it comes before or even comes itself alone as a relapse. That can always be hard to sort out from other problems. So it may be a primary symptom at times, but certainly it's influenced by many other factors, as many people without neuroimmunologic disease will suffer from fatigue. It significantly influences functional outcomes, and the mechanisms unknown. And there's also little agreement about optimal management. But there are some guidelines, and these come out of the MS Fatigue Clinical Practice Guidelines, and were put out in 1998. And they were developed jointly by a sort of umbrella of organizations, the MS Council for Clinical Practice Guidelines. And that was sponsored by the Paralyzed Veterans of America. And basically, they suggest that this should be a diagnosis of exclusion, and you should look for other causes of fatigue first. And that the approach to treatment should include a combination of self-help education, pharmacologic management. We do have a few drugs to try. Attempts to be effective and efficient in using one's energy supplies, exercise, and then equipment modification, making life more efficient and useful. So one of the major things is to rule out other causes of fatigue. Certainly sleep disorders are a common problem in the general population and are probably increased in number in many neurologic disorders, including neuroimmunologic disorders. We want to look at other medical conditions that might cause fatigue. Depression is always going to keep rearing its head here. And then medication side effects. And also we want to look at secondary complications of MS. So if there's significant weakness, how can we use tools or aids for ambulation, for instance, to spare energy? Pain will complicate sleep and fatigue. And then there are there's a string of studies in the literature about whether there's inefficient respiration, which is probably not a major factor in most people with MS. Sleep disorders are pervasive and under-recognized and include insomnia and nocturnal movement disorders such as restless leg syndrome, various problems with disordered breathing, including sleep apnea, and narcolepsy is increased in MS. In addition, more commonplace problems are pain of various types from lying in bed, nocturia, having to urinate several times during the night and get up, spasticity, and depression affects sleep, and then medication effects. So all kinds of things we can work on to improve sleep quality. Okay, and non-pharmacologic therapy of fatigue. Well, there are some major set of studies in the literature. Many of them are small but of good quality that show benefit for MS fatigue for training programs that unfortunately seem to require a lot of supervision, all right, or one-on-one or at least close supervision. These are combinations of aerobic conditioning and weight training. And these are generally closely supervised programs with very slow graded increases in intensity. So if you overdo it too fast, then everything will hurt and you'll just be set back beyond square one. Aerobic exercises that incorporate balance training and socialization are recommended, and then general education about energy conservation. Cooling therapies can be useful for fatigue. Okay, and I won't dwell on that because of time. There are some nutritional practices that may be helpful for fatigue. All of us have experienced being tired after eating too large a meal and maybe having trouble attending in lecture. So things such as avoiding large meals and maybe eating frequent small meals, adequate hydration, the nutritional gurus suggest, avoiding refined sugars and carbs that give you a high and then a low, avoiding tobacco, alcohol, caffeine, all those good things that we try to do and don't always succeed. In addition, there are medications to try. The recommended treatments in this 1998 guidelines were amantadine as a first-line drug and pemoline that's sort of fallen by the wayside. Modafinil or Provigil is a drug that's commonly used and may be added to guidelines in the future. And then there are drugs that require further study that might be useful. Just a little bit about amantadine. We've talked a little bit about neurotransmitter systems and dopaminergic agent. That's one of the activities, a rather weak agent for this, but it seems to be a little activating. It has some other activities in the neurochemistry. Its side effects, the common ones are nausea, lightheadedness, and insomnia, but generally in the neuroimmunology population, which is younger than, let's say, a Parkinson's disease population, it's well tolerated. I hardly ever have problems. But sometimes we'll hear of someone with irritability, depression, hallucinations, constipation, peripheral edema, and rarely these things that are more severe. There have been several clinical trials of this drug. They were mostly done quite earlier in the 80s, and they were small groups, all right? There has been a development of various surveys to measure fatigue and try to take out or deal with confounding issues such as depression or weakness. And so we think we have better scales than we did then that might be more sensitive. But several of these studies, and I'm not going to go through them in detail because they're in the notes in time, did show benefit for amantadine over placebo. So we usually use 100 milligrams in the morning and 100 milligrams at noon or in the early afternoon as a typical dose. Okay. So the conclusion is that there are 4 clinical trials and 20 to 40% of mildly to moderately disabled MS patients showed significant short-term reductions in self-reported fatigue. This drug's well tolerated, and some people become refractory to benefits from long-term therapy but might benefit from a drug holiday and then coming back to it. Pemoline was always given as a second-line agent, and it's a stimulant not related to amphetamines or Ritalin. Unfortunately, it has become associated with a slow accumulation of cases of liver failure and is basically phased off the market. There was one study supporting its benefit. And then one study that showed no benefit compared with placebo or amantadine. Now, as far as modafinil, this is a non-amphetamine central nervous system stimulant, and it's an interesting drug. Because it causes selective activation of wakefulness centers or vigilance centers in the hypothalamus and medial forebrain, unlike amphetamines, which just cause more widespread activation of the brain. And it's first indicated for narcolepsy, but now has a wide range of indications, including sleep disturbance, shift work problems, idiopathic hypersomnolence. However, it's an expensive drug, and it's not FDA approved for MS-related fatigue. It's very safe. It's non-addictive. Animals won't press a bar a million times to get it, like some drugs. And the rare side effect is a headache for some, occasional anxiety. The studies have been small. Our group actually was involved in a study that had a positive benefit, but there have been negative studies as well. And basically, there's an inconsistent insurance company willingness to cover the drug. But maybe eventually the patent will run out and it'll become cheaper as they're trying to develop a more advanced form, more selective form. Other medications for fatigue, none of these have good studies out, but are just being empirically tried: methylphenidate, amphetamines, other stimulants used for attention deficit disorder, and 3,4-diaminopyridine is being developed and studied. So, summary, fatigue may be a primary or secondary symptom of MS, and evaluation should take into account a thorough, a look at other causes besides just the MS. There are comprehensive management strategy guidelines. There are some drugs that are effective for some people. I'm not sure how in the MS population some of the immunomodulatory drugs such as interferon are known to maybe worsen fatigue some. And basically, long-term management is going to require quite an effort between physician and a person with a neurologic disease to optimize the condition. So I'll stop there.